Warm greetings from Kasturba Medical College and Hospital, Manipal, Manipal Academy of Higher Education, India. Myself, Dr. Kavita Sarao, Professor and Head, Department of Infectious Diseases, and the organizing chairperson of this conference, have the pleasure to invite you all to the 4th day of International Conference on Antimicrobial Resistance, Combating the Same. This conference has been organized. Today's program has been organized by the Department of Infectious Diseases and Manipal Center for Infectious Diseases. Critical illness and antimicrobial resistance are the deadly duo and can be devastating. Critical illness patients have multiple comorbidities and the treatment outcomes are still poor. Can individualized dosing of antimicrobials overcome these limitations? Also, the theme of the World Antimicrobial Awareness Week is Antimicrobials Handled with Care. While we strive to give right antibiotic earliest to the patients who are critically ill, it's elemental to prevent overuse of antibiotics. This is the balance which every clinician must strive to practice. So today's 2 lectures, I'm sure, is going to throw light in this direction and educate all of us much better. I have the pleasure of introducing today's moderators, Dr. Vishal Shanbag, Critical Care Physician at Kasturba Medical College, Manipal, and Dr. Jairaj, Professor and Head of Department of Emergency Medicine at Kasturba Medical College, Manipal. Over to you for taking over the proceedings. Vishal and Jairaj.
Good afternoon, madam. Thank you for the kind introduction. So we'll come to today's first session, drug dosing in the critical care. It's my pleasure to introduce Dr. Jason Roberts. So he's a consultant clinical pharmacist at Royal Brisbane and Women's Hospital, Queensland. He also serves as a research chair for University of Queensland Centre of Clinical Research. He's a clinician scientist with a strong interest in research. In principal research theme is optimization of antibiotic dosing in critically ill. He had been awarded more than 30 million grants for research, and he published over 450 papers and books and lot of books in the chapters in the books. Currently, he supervises around 22 higher research degree students. He has served on the critical care review panel for ATS and IDSA guidelines for hospital-acquired pneumonia, healthcare-associated pneumonia and ventilator-associated pneumonia, and Australian Therapeutic Guidelines, Antibiotics and 2021 Surviving Sepsis Guidelines. His editorial board of various peer-reviewed journals such as International Journal of Antimicrobial Agents, Journal of Pharmacy Practice and Research, the Journal for Society of Hospital Pharmacists of Australia, Pharmacotherapy and Anesthesiology, Pain and Critical Care Medicine Journal. So with this short, brief introduction, over to you, Dr. Jason.
Well, good evening, everyone. It's a pleasure to be here. I'm just going to share my slides. Okay, I hope that's coming through clearly now. So it's an absolute pleasure to participate in this meeting. I have really fond experiences of traveling in India and speaking to healthcare professionals about this very topic. And so I know that India is a big place, and so I haven't spoken to anywhere near as many as I should. So it's an absolute pleasure to accept this opportunity to talk to you about a topic which I'm really quite passionate about, which is antibiotic dosing in intensive care unit patients. And of course, this is a topic that aligns very well with the theme for World Antimicrobial Awareness Week, which is, of course, handling antimicrobials with care. And that's what optimized drug dosing is all about: personalizing drug dosing to the needs of the individual patient, taking care in the selection of those doses, just like we do in the selection of the drug itself. And as I hope that I'll be able to demonstrate to you throughout this presentation, is that if we are able to optimize the way that we dose antimicrobials, then we can dramatically increase the likelihood of a good therapeutic outcome for patients. And indeed, one of those outcomes may be the minimization of the emergence of drug-resistant pathogens. And so, again, that's very important for considerations of antimicrobial resistance in this important week in the healthcare calendar. So I've just got some disclosures that I'd like to make on this slide, just for your reference, but none of these are relevant to today's presentation. So these are the contents of what I hope to get through in the next 35 to 40 minutes or so. Firstly, to talk about why there are challenges with antimicrobial dosing. What is it about critically ill patients that make them particularly challenging for clinicians in aiming to provide the best possible therapy for them? And then to provide an understanding of why pharmacokinetics and pharmacodynamics, or PKPD, is so important to optimizing treatment in critical care. And in doing so, I want to go through three specific patient groups, or some characteristics which are associated with different treatment interventions that we can provide, and the effect that this has on drug dosing requirements. So to talk about augmented renal clearance, or ARC, renal replacement therapy, or RRT, and extracorporeal membrane oxygenation, or ECMO. And then to bring all of that information together to then talk about what the consequences of this new information that we have into a framework which we can use for better antimicrobial dosing for the benefit of our patients. So importantly, what we need to consider is why we need to individualize doses at all. Why is it that standard doses that are found in the product information for antimicrobials are inappropriate? And the rationale for that really comes from the fact that the registration trials upon which the dosing regimens that are found in the product information are based on a certain behavior of drugs in a certain patient population. So to explain this a little bit more, to understand what a drug dose is, to define what a drug dose is that should be used in patients, this typically starts in the laboratory, whereby in vitro studies or in animal studies, the exposure of an antimicrobial that's able to kill bacteria is defined. Once we know what that specific exposure is, some clinical studies are then undertaken, predominantly or initially with healthy volunteers, to make sure that those kind of exposures which were able to kill bacteria are actually safe and tolerable in humans, and so they tend to be done in healthy volunteers. And then by combining knowledge of the behavior, so the pharmacokinetics of those drugs in the healthy volunteers, with what exposures are known to be appropriate from the laboratory studies, some dosing regimens are proposed, and they are then taken forward into phase 3 clinical trials. And if there is a positive effect demonstrated of that drug in that scenario, then effectively those dosing regimens in that patient population has been appropriately validated. So when the dosing regimens aren't appropriate is when the behavior of the drug or the pharmacokinetics is different to the pharmacokinetics of the patient populations that are seen in registration trials. Why is this relevant to critically ill patients? Well, that's because critically ill patients are rarely considered as part of registration trials. Almost always they include patients that are in a ward-based scenario, are not obese, they will not have significant organ dysfunction, and they'll be quite homogeneous in comparison to the kind of patients that will then later receive that drug. And so this is an important justification for why we should be thinking about the patient population in who that drug, that dosing regimen has been developed. And I do want to pay credit to a lot of pharmaceutical companies who are making a bigger effort in these phase 3 trials to include critically ill patients, because they're obviously an important group. But as I mentioned before, patients with renal failure, liver failure, those that are obese, those with significant burn injuries or cystic fibrosis patients, those that may have solid organ transplants or receiving some sort of extracorporeal therapy, these are patient groups who are not studied commonly in those registration trials, and therefore there is an uncertainty about the appropriateness of dosing some of those dosing regimens in those patient groups. And that's why an understanding of pharmacokinetics of the drug is important. The other very important point to note about antimicrobials, which is quite self-evident, is these are not drugs which we can titrate to a measurable pharmacodynamic endpoint, and therefore can't intrinsically personalize the dosing to the needs of the individual patient. If we think about a vasopressor drug, whereby we can titrate dosing to a mean arterial pressure target, or a sedative drug, whereby we may choose to titrate the dose in an individual patient to a desired level of sedation, these are almost end of needle effects that we can be titrating dosing to, but we can't do that with antimicrobials. Looking for specific biomarkers or alternatively clinical markers of infection and trying to monitor for changes of these to give us a guide about whether our dosing is appropriate just isn't appropriate, because that can take anywhere from 24 to 48 to 72 hours. And if we're waiting that long to find out that our doses were appropriate, then that can be catastrophic for the patient. So importantly, antimicrobials, almost more than any other drug class, have a clear concentration effect relationship. Now, this is very clearly demonstrated in vitro studies and animal studies as well, whereby small modulations of the concentration of the antimicrobial can be shown to have dramatically different effects on the capacity of that antimicrobial to kill bacteria or to even prevent the emergence of resistance. When we think about this in the context of clinical studies, we know that it is not really ethical for us to conduct a study whereby we randomize a patient to a low exposure of drug versus a high exposure of drug, or a therapeutic and a non-therapeutic exposure of drug. And so most of our descriptions of a drug concentration target, which is associated with a better outcome, tends to come from observational studies where pharmacokinetic data has also been collected. And that's essentially what this slide is describing here. Importantly, you'll note that for almost all the different drug classes that we use in clinical medicine and in critically ill patients to treat severe infections, they all have an exposure of drug which has been defined to be associated with a better clinical outcome. Now, almost always this is done in the context of improved clinical cure, but in some cases it's done in the context of improved survival. And so again, this provides more evidence to us to support the fact that drug dosing is important. And if we can achieve particular exposures of drug, which will need a patient-specific dose to achieve that, then we can increase the likelihood of them having clinical cure and hopefully, of course, having a very good clinical outcome. So I wanted to draw each of your attention to this specific paper. Now, this is a position paper which our group was fortunate enough to lead and was published in the journal Intensive Care Medicine in October of 2020. But this is a position paper which was constituted of key opinion leaders from 4 international societies: the European Society of Intensive Care Medicine, the European Society for Clinical Microbiology and Infectious Diseases, the International Association of Therapeutic Drug Monitoring and Clinical Toxicology, and the International Society for Antimicrobial Chemotherapy. Each of those organisations contributed specific members to this group, who then worked on a position paper to define the importance of therapeutic drug monitoring. Now, although in this specific presentation we haven't got to that topic of therapeutic drug monitoring, this paper is very useful because it goes through the background about the altered pharmacokinetics and altered dosing requirements that are likely to be needed in critically ill patients, and so has some important information in that regard. And then also provides a framework through which therapeutic drug monitoring or other PKPD-based dosing approaches could be used. And so I wanted to spend a little bit of time reflecting on that paper and provide you with that citation. So next I wanted to talk about what some of the key PKPD considerations are in critical care. So what is PKPD? Okay, so it's pharmacokinetics and pharmacodynamics. Pharmacokinetics, as its own definition, essentially is the relationship between a dose of drug that's administered and the concentrations that are observed in the body. Pharmacodynamics, on the other hand, is the relationship between a concentration of drug and the effects that the pharmacological effects that it exerts. So pharmacological effects from antimicrobial are typically bacterial killing, but can also be considered in the context of suppression of emergence of resistance. So PKPD itself links the dose of drug with some kind of endpoint. So antibiotics, as I mentioned previously, they have a very strong exposure effect relationship, and dosing that does not align with PKPD will result in suboptimal effects because it won't achieve those exposures which are known to be associated with better outcomes for patients. Well, we'll certainly achieve those less consistently. And so although we spoke about this in the context of clinical failure in terms of an inability or insufficient bacterial killing and potentially the emergence of resistance, it can also lead to drug toxicity. And we see this quite frequently and traditionally with drugs like gentamicin and vancomycin, whereby inappropriate dosing leads to nephrotoxicity and ototoxicity. But we're seeing this increasingly with other drug classes as well, as we look for effects which are associated with excessive concentrations. And so for Betalactams, there's a broader understanding of neurological worsening in these patients with very high drug exposures. And so this is why therapeutic drug monitoring, as one potential entity to improve the accuracy of dosing, has been mooted and should be supported, because it increases the likelihood of achieving optimal exposure, because you're measuring a concentration in that individual patient, and then you're choosing a new individualized dose based on information you have from that patient. So what is it about critically ill patients that makes dosing so challenging? What it really comes down to, from my perspective, is the spectrum of organ function that is possible in an intensive care unit. Now, I'm sure that all of the different participants on this webinar have been into an intensive care unit, and you've walked around an intensive care unit and have seen the wide range of patients that there may be throughout the unit, and how contrasting one patient can be in one bed versus a patient in the next bed along. So when I am working in a clinically and I'm trying to decide what kind of dosing regimens that we should be using for patients, I tend to quite crudely think about a graphic like this to try and categorize what kind of patient it is. And so if we think about these categorizations, we can have some patients that are very hyperdynamic. So this is the graphic on the far left side, whereby essentially they are responding to some sort of insult, which could be trauma, it could be infection, it could be a burn injury, pancreatitis, a neurotrauma, for example. And as part of that response to that insult, and before they've developed any end organ dysfunction of the kidneys and the liver in particular, they can become very hyperdynamic. And this will lead to an increased cardiac output. Now, that increased cardiac output, of course, increases perfusion of those eliminating organs, like the kidney in particular, but also the liver. But if it's a renally cleared drug and you're increasing the delivery of that drug to the kidney per unit time, then you will see increased drug clearance. And therefore, relative to other patients that don't have that same presentation, you will see much lower drug concentrations. The next categorization along can be related to that group as well, but also can be related to some of the other categorizations and refers to the context of whereby patients have an altered fluid balance. Now, this is very common, of course, for patients that are unable to support their own blood pressure and require fluid resuscitation. That excess, that fluid that is provided to those patients to maintain their blood pressure, often because of the presence of leaky capillaries, will cause an edematous state, whereby the fluid has leaked into various peripheral tissues. And what that can mean is that because we've given effectively an extra volume of water, which could be anywhere from 2 to 5 to 10 or even 15 litres in severe burn injury patients, this can lead to effectively a dilutional effect for drugs that are water soluble because there's more water present in the patient. And this then manifests as an increased volume of distribution because it aligns with those specific, that pharmacokinetic definition. If it has that dilutional effect, then of course that can also lead to lower drug concentrations. Of course, there can be some patients that don't have any organ dysfunction and therefore have effectively very similar dosing requirements to patients typical patients in a general medical ward or a general surgical ward. Then there are those patients that are more commonly considered in the context of critical illness. They're those patients that have a renal and or hepatic dysfunction. And typically those patients will have an increased volume of distribution, but decreased drug clearance because the drug isn't being removed as quickly. And almost always the clearance aspect is what tends to dominate the dosing requirements. And so even in the context of an increased volume of distribution, we'll tend to see higher drug concentrations if we use a renally, as if we don't adjust the dose properly. And then finally, we have those patients that may have an organ support requirement. So this is, I'm talking about renal replacement therapy or ECMO here. And these patients can have definitely an increased volume of distribution, but the effect of this on the clearance of the drug from the body is very dependent on the modality and the settings of those treatments which are used. And so that's why I remark here that it can have a decreased or an increased effect on drug concentrations. So at the moment, that schematic, that presents just a theoretical approach to considering altered pharmacokinetics. But of course, you would have noted from the preceding slide where we were describing the PKPD targets that are associated with better clinical outcomes, that in each of those, the MIC, so the minimum inhibitory concentration, which is a measure of susceptibility of the pathogen to that antimicrobial, was the denominator in each of those PKPD indexes. And so that means that although we can consider the altered pharmacokinetics, we do need to also be aware of what the pathogen is and what the likely or alternatively possible, what the actual MIC is. Because if it's a highly susceptible pathogen causing the infection and we have just a normal reasonable dose of drug, it's highly unlikely that our dosing is going to be inappropriate. But when it gets closer to a higher MIC, which is closer to the MIC breakpoint, that's when we tend to run into problems with drug dosing appropriateness and the need for personalizing the dose to the individual scenario of the patient, the altered pharmacokinetics, as well as the MIC of the pathogen becomes more important. So we've looked at this, this topic of altered pharmacokinetics just in the context of just a broad schematic. What about looking at some of the pharmacokinetic data to describe how different some of these pharmacokinetic parameters can be between a critically ill patient, so a patient in the ICU, versus a healthy volunteer? On this slide here, which is from a review paper that we did back in 2011 or so, you can see that we've got a range of different drugs there, some beta-lactams, glycopeptides, and fusidic acid, describing a change in drug clearance in ICU patients and a change in drug volume of distribution in ICU patients where that was reported. Essentially, you can see there are substantially higher values which are reported in ICU patients. And so this, of course, means that there is a higher drug clearance and a higher volume of distribution, and this can lead to dramatically lower concentrations, particularly earlier in the course of therapy for patients, demonstrating the importance of using ICU-specific dosing, and in particular, dosing appropriate to the individual ICU patient, as opposed to product information dosing, which most commonly is based on data from healthy volunteers. So let's talk a little bit about beta-lactam pharmacokinetic variability in ICU patients. Why beta-lactams? Because, of course, they're the most commonly used drug class that we use in all of medicine, really. This is data from a study called the DALI study. So the DALI study stands for Defining Antibiotic Levels in Intensive Care Unit Patients. And this was a multi-center pharmacokinetic point prevalence study, which was performed in 68 intensive care units in 10 European countries. This was a study that we were very proud to coordinate from Australia with the support of the European Society of Intensive Care Medicine. Here on this graphic, we have 8 different beta-lactam antibiotics representing, I think it's about 375 patients worth of data, with concentration on the y-axis. And you'll note that that's not a linear scale, that's a log2 scale. Essentially, the main point to take away from this is that drug exposures, trough concentrations, are highly variable in critically ill patients. And here we can see up to 500-fold variability of beta-lactam concentrations. So if you think about what the contemporary approach to dosing is that basically for piperacillin, we use pretty much a standard dose in all patients. But the point to note is you don't get a standard exposure or a consistent exposure in all of those patients. And as you can see there's up to 500-fold variability in exposure, with some of those exposures being very, very low, well below what we would consider to be even an acceptable exposure of drug. And so this heightens our understanding of what happens with a one-dose-fits-all approach to dosing and makes us realize that we potentially should be more selective in our dosing approaches to individual patients. So I hope this slide's projecting properly. This is one of the tables from that antimicrobial TDM paper, the position paper that I referred to earlier. And essentially what this does for all of the different drug classes is it defines what the PKPD index is. So is it a drug which requires a high peak concentration to MIC ratio? So that would be, of course, an aminoglycoside. Is it a drug which is more related to the time for which antimicrobial concentrations are maintained above the MIC, which would be a time-dependent drug like the beta-lactams? Or is it an AUC-MIC drug, where the AUC stands for the area under the concentration time curve, and that's essentially an integration of the area under a concentration time curve. So it's a measure of the total exposure. It also describes the PKPD targets for efficacy based on preclinical studies versus what's been demonstrated in clinical studies, and also the threshold associated with drug toxicity as well. And so this is very useful because what it helps define is the kind of exposures which one should be aiming for when dosing drugs in critically ill patients in particular. Now, where we don't have therapeutic drug monitoring for a drug, this provides less value because you don't have a concentration measurement which you can directly compare with the PKPD target. But what it does do is it gives you a sense about the kind of exposures that have been defined relative to what may have been described in healthy volunteer pharmacokinetic studies, so you can see what order of magnitude higher dosing is required. And so if I could give an example of this in the context of ciprofloxacin. So ciprofloxacin was a drug that was initially launched at a dose of 200 milligrams every 12 hours or every 8 hours back in the late 1980s, early 1990s. And it was quickly observed that resistance was emerging to this drug in some patients, and that some patients weren't necessarily benefiting from that drug. And so a group in Hartford, Connecticut in the USA performed an observational pharmacokinetic study where they also collected patient outcome data using drug exposure combined with MIC data that was available, and then comparing those results with patient outcome. They were able to show that a much higher area under the concentration time curve relative to what was achievable with low 200 milligram BD or 12-hourly, 200 milligram 8-hourly dosing was able to achieve. And they demonstrated that a dose closer to 400 milligrams every 8 hours, so double of what was in the product information, would be required in most patients to achieve a target AUC-MIC of 125 for particularly for Pseudomonas infections. And so that's a classical example of how a post-marketing study has been able to redefine dosing requirements for a drug. And that kind of information is what is included in that table. Now, I want to talk just very briefly on pharmacodynamics in the context of susceptibility patterns. Now, I referred to the importance of MIC before, but I didn't describe its importance in the context of critically ill patients. And that's because the intensive care unit is a highly protected area whereby you can have patients that have prolonged lengths of stay. They're more likely to have multiple courses of antimicrobials because of multiple infections that they may develop over the course of their stay. And in doing so, they're more likely to have, of course, more resistance or less susceptible organisms causing infection. And this is something which has been described in a number of epidemiological studies, whereby in this specific example here, which is a German surveillance study of carbapenem MICs, that in critically ill patients versus ward-based patients, that ICU patients or critically ill patients had MICs for their pathogens, which were 2 to 3 dilutions higher than was the case for ward-based patients. So that's important because that essentially means that not only do we have altered pharmacokinetics to deal with, but we also have altered pathogen susceptibility relative to what we would see in a ward environment. So if we bring together this altered pharmacokinetics and this altered pharmacodynamics, and we talk about, well, in a large cohort of patients that we have data for, what is the effect then of current dosing on the ability to achieve those drug concentrations and exposures which are associated with better patient outcomes? So again, this is data from the DALI study, 8 different Betalactam antibiotics, so over 350 patients worth of data. And this time on the y-axis, instead of concentration, we've got a PKPD ratio, which is what I would consider to be quite a conservative target of 50% time above MIC. So that the dose, the concentration of the drug needed to exceed the MIC for at least half of the dosing interval, which is an exposure supported by in vitro studies. Essentially, what this study found is that about 16% of patients didn't achieve that target. So that's nearly 1 in 5, 1 in 6 patients. And then they were 3 times more likely to fail treatment. So that's quite a significant proportion of patients that aren't getting appropriate exposures of drug. And there is data from this study showing they're failing therapy. In terms of what's more likely to be an appropriate exposure, about 45% of patients didn't achieve that more aggressive exposure, which is closer to those PKPD targets, which were defined in the position paper. So that demonstrates a lot of where we have to go. So there's a lot of background there, but I think that's all very important. So now I want to talk about augmented renal clearance. So augmented renal clearance is defined as a creatinine clearance greater than 130 ml per minute. Now, this was something which we defined back in about 2010 or 2011 and was the subject of the PhD of an intensive care physician called Andrew Udy, who did some fantastic work in this area. This is one of the studies that we put together trying to demonstrate the effect of augmented renal clearance on drug exposure. So on the x-axis, there's creatinine clearance, which was a measured urinary creatinine clearance. And on the y-axis, there's a trough concentration to MIC ratio. Now, as you'd expect, as renal function increases, as you start to see a much higher creatinine clearance, you will see lower drug exposures. And that's something which, of course, is well known for beta-lactam antibiotics, which are almost exclusively renally cleared. And so this is data from 51 critically ill patients who are receiving a beta-lactam antibiotic as part of the therapeutic drug monitoring program that we have at our hospital for beta-lactams. But what's particularly interesting here, and unfortunately it's not coming out very clearly in this graphic, is that some of the patients had creatinine clearances greater than 200 and 250 ml per minute. Now, for us as in the audience here, I'd like to think of us all as relatively well and fit people. We would probably have a creatinine clearance somewhere between 100 and 150 ml per minute for younger people that may be listening. But some of these patients, because of that inflammatory process that develops in critically ill patients in response to some sort of insult, like infection or trauma, they can develop much higher drug clearances. And that's certainly what we're seeing here. Creatinine clearances as high as 300 ml per minute, and that was associated with very low drug concentrations. Note that that's a log 10 scale on the y-axis. What are the consequences of that then for patient outcome? Because that's obviously quite important. This is an observational study from Jan de Waele's group, who works at Ghent University Hospital in Belgium, and essentially comparing the outcomes for patients with augmented renal clearance on the right-hand column versus the middle column for those patients that did not develop augmented renal clearance. Essentially, patients who developed augmented renal clearance had a 27% likelihood of failure versus 13% in the non-augmented renal clearance patients. So this is a study of only 130 patients or so, but it's essentially, it's quite powerful in demonstrating what the high failure rate is associated with augmented renal clearance, in all likelihood because of low drug concentrations. What about a stronger, more robust trial? Well, this is a really important study, a very sad study in many ways about Durapenum. Now, Durapenum is supposed to be a microbiologically superior carbapenem to all of the other carbapenems, and was developed by Johnson & Johnson as a drug which is able to provide enhanced outcomes for patients. And so Johnson & Johnson subjected to a phase 3 multi-center double-blinded randomized controlled trial for patients with ventilator-associated pneumonia and compared a fixed 7-day course of Durapenum versus a fixed 10-day course of Imipenem. Essentially, halfway through the study, the Data Safety Monitoring Board had to terminate the study because of patients in the Durapenum group, so the microbiologically superior Durapenum group, were more likely to fail treatment. Now, when they did some sub-analyses to try and investigate why that was the case, there was a dramatically increased likelihood of patients that had a creatinine clearance greater than 150 ml per minute that were likely to fail treatment in the Durapenum group versus the Imipenem group, raising questions about, was the dosing regimen that was put forward in this study appropriate given what the likelihood of patients in the ICU developing augmented renal clearance was? And clearly the answer here was no. And we subsequently did a dosing simulation study afterwards to demonstrate that indeed that dosing regimen which they had used would have been insufficient and is most likely the reason for why Durapenum has largely been lost from the international market. So, it's a very important consideration even in drug development. What about renal replacement therapy? Well, this is some data that I wanted to present to you from the SMART study. The SMART study stands for Sampling Antibiotics, Antimicrobials and Renal Replacement Therapy. This is a multi-center pharmacokinetic study conducted in about 29 intensive care units around the world. I think it was about 14 countries that participated in this. Again, another study that we're very proud to have led. And on this slide here, there's just some demographic data, which is pretty consistent with what you would expect to see for patients with renal replacement therapy. Something which was particularly interesting in that first table there is a parameter described as ETRCL, which is essentially the estimated total renal clearance for these patients, which is trying to find a surrogate for creatinine clearance. And typically when I would be trying to establish or calculate a dose which may be appropriate for patients with renal replacement therapy, I tend to guess a dose of, a creatinine clearance of 30 ml per minute as a substitute. But what was found in this study here is that it's actually closer to 50 ml per minute in terms of an average creatinine clearance equivalent that is caused by the presence of renal replacement therapy. So I think that's a really important thing to consider. The table on the right just essentially shows the vast range of dosing regimens that we used in these patients. What that demonstrates is the dramatic uncertainty that people have about what dose of drug that they should be using in different forms of renal replacement therapy. If we look at the pharmacokinetic outcomes associated with this study, is that, again, highly variable pharmacokinetic data for meropenem on the top left, piperacillin top right, tazobactam bottom left, and then vancomycin bottom right, and that many patients don't achieve what we'd consider to be a minimum therapeutic target, and many patients also have excessively high concentrations where it's likely that they are at risk of drug toxicities. There was also some relationships associated with drug exposure and patient survival as well described in this study. So this is an important paper published in 2020 in Clinical Infectious Diseases. What about ECMO? So the main concern with ECMO really is this picture on the top right corner of the slide. So this is the oxygenator and all of the tubing which connects the bloodstream to this. It constitutes a large surface area, and as many of you will know, there's a lot of literature going back 5 decades describing the adsorption or the sticking of some drugs to different types of plastics. And that's really what the concern is with ECMO. And some of the in vitro studies have demonstrated that, in particular, highly protein-bound drugs and drugs that are lipophilic, which are most likely to be at risk of binding to the oxygenator and therefore to have much lower drug concentrations. But really, other than that, it's probably okay, and you just dose according to what the patient's organ function is. One study which I think demonstrates that quite nicely is this pharmacokinetic study, which is a collaborative undertaking between our group and Fabio Tacconi's group in Erasme Hospital in Belgium, whereby we combined 2 cohorts of patients receiving meropenem. Patients that received meropenem with ECMO and those that were critically ill patients that didn't have an ECMO requirement. And we tried to match them as best as we could. Then we subjected to a formal pharmacokinetic modelling process and essentially found that the most important factors associated with the need for altered dosing was the presence of renal replacement therapy. And if the patient didn't require renal replacement therapy, then it was what their creatinine clearance was. ECMO wasn't considered to be a statistically significant variable at all. And so this is one piece of data, and there's a number of studies which have come out since for other drugs which have demonstrated that dose adjustment for beta-lactams, generally speaking, in the context of ECMO, don't need to be done because of the presence of ECMO. It should be based on renal function estimates or drug clearance estimates on their own. And so there is some interesting data which is coming out from the ASAP ECMO study. We've now got 3 papers which have been published on this, with more to follow. And essentially that antimicrobial data which has been published so far, which constitutes data from over 100 patients receiving ECMO, demonstrates that for drugs which have low protein binding, that are more hydrophilic as opposed to lipophilic, don't need to be dose adjusted because of the presence of ECMO. So what conclusions can we make based on all of this data? Well, firstly, that the key opinion leaders in our area tend to agree with us that pharmacokinetic, pharmacodynamic based optimization of antimicrobial therapy is very important. So this is one of the recommendations from the Infectious Diseases Society of America and the American Thoracic Society clinical practice guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia. And this was very much a key recommendation that they provided, that although the quality of evidence, as I've already shown you, is quite low because a lot of the data comes from observational studies, that the consistency of the data supporting the need to achieve a therapeutic exposure of drug suggests that a recommendation was appropriate to be made for antibiotic dosing to be determined using PKPD data. So essentially going through all of the processes that we've been talking about today and using each of those considerations. Now, in the bottom right-hand corner of this slide, you'll see a very small table, but essentially these are the recommended empiric doses for various antimicrobials, which take into account each of those different factors that we've been talking about today. That take into account the potential for significant augmented renal clearance, the potential for dramatically altered volumes of distribution. And so, those dosing regimens for the beta-lactams as well as quinolones and aminoglycosides are described there. There's also data that exists for other drugs as well, which we'll talk about on this next slide. Because one of the important things for us to be thinking about is that, all right, so we can understand, okay, that dosing needs are different, but how do we actually go about using a different dose? Well, a lot of it depends on the resources that are available to you. Of course, if you're a resource poor setting, then there's only so much you can do in terms of the kind of interventions you can make. But something you can do is you can use dosing regimens using the same dose of antimicrobial, same daily dose, but apply that to, use that dose in line with what the PKPD characteristics of the drug are. And so I would call these unit level interventions, whereby essentially for that class of drug, you use that approach to dosing for all of the patients that you have. So one example would be prolonged infusion of beta-lactams, whereby instead of giving beta-lactams as a 30-minute infusion, as would be recommended by most product informations, you would give it as an infusion which runs for at least half of the dosing interval, if not as a continuous infusion. And of course, this has been a topic of the BLING research program, which I'd be happy to talk about a little bit later on. But prolonged infusion of beta-lactams has now been endorsed by the Surviving Sepsis campaign guidelines, which were released in October of this year as one of their interventions which is recommended for application in patients with sepsis. So prolonged infusion of beta-lactams, it doesn't cost any more. It's something which is a very applicable intervention. Another is extended interval aminoglycosides. So this is, instead of giving aminoglycosides as the traditional 3 times daily dosing, as I have seen does still occur in some countries around the world, surprisingly, and has come through in some surveys that is done, that you just convert that overall daily dose, which you would usually split into 3 doses, into a single dose and give that once a day. That's certainly far better for achieving a higher Cmax, a higher peak concentration, and also results in lower trough concentrations, which therefore minimize the likelihood of drug toxicity. And systematic reviews and meta-analyses consistently demonstrate that that is by far the most appropriate way to use aminoglycosides. The second option you could do, again, this doesn't need a lot of resources, is to apply dosing nomograms, which have been developed in critically ill patients, to choose a dose which is specific for the patient in front of you. So commonly we would do this with aminoglycosides with a weight-based dose, so a milligram per kilo based dose, also done with drugs like ticaplanin as well. Vancomycin also has weight-based loading doses, for example, as well. But you can also use creatinine clearance-based dosing for renally cleared drugs. And so there are nomograms for creatinine clearance-based dosing of vancomycin, including creatinine clearances up to as high as 250 ml per minute. And there are also nomograms for Betalactams, including Durapenum, but also Piperacillin tazobactam, whereby essentially you're just reading off a sheet of paper what the appropriate dose is based on the patient's measured renal function. Where increasing resources are required, this is when you could apply things such as dosing software, whereby essentially this has a pharmacokinetic model embedded in a piece of software which has an easily usable interface, and then you can put in information about the patient. It'll then run that information through the dosing algorithm and provide you with a recommended dose. And of course, the final option is therapeutic drug monitoring, which I don't want to go into too much detail other than to say that for, where it is available, definitely should be used, because it's the only way of ensuring that all patients achieve a therapeutic exposure. Because with all of those other interventions, although they are better than just standard dosing, this approach is the only way that you can ensure that take out the effect of pharmacokinetic variability, which impairs the others. Almost all drug classes now have had studies published on therapeutic drug monitoring application of these. And so it is something which is available in only small parts around the world for all drugs, but it is something which I think we're going to learn a lot more about in the years to come. So I'll conclude there by just reminding you that there is a clear concentration effect relationship for antibiotics. And although many patients can be administered a typical dose, if it is a patient which has rather extreme pharmacokinetics, then you won't achieve those concentrations that are associated with the higher likelihood of achieving an appropriate exposure for that patient. And I hope that this extensive description about pharmacokinetics can assist you as you try to calculate what the likely altered pharmacokinetics are in each individual patient that you treat, and therefore can ensure that you are more likely to choose a dose which is specific for that individual's requirements. So I'm happy to conclude there and then pass over back to my wonderful chairs for this evening.
Thank you so much, Dr. Jason. At the outset, I would like to thank you for the wonderful presentation. Actually, I had made 4 points which I wanted you to address. One of them was augmented renal clearance. The second was about PKPD dosing and modification of dose in ECMO. And third was about continuous infusion of beta-lactams. And fourth was about therapeutic drug monitoring. I think most of them we have covered in your talk. So I think that's wonderful that, whatever we wanted to get out of your presentation, you have addressed very nicely. And I think that's a real reason why we should have a clinical pharmacist in our ICU rounds. I feel it's essential part of critical care. I have been worked with critical care pharmacists for the last 6 years before, and I really see changes happening in patient outcome when we take an advice from clinical pharmacist and use interventions advised by them, especially for ECMO patients or patients who are having a dialysis. Just wanted to ask one more point, like what's your opinion about using nebulized antibiotics? Like when you use some of the patients with ventilator-associated pneumonias, we tend to use nebulized cholesterol or aminoglycosides. So I just wanted to take your point of view on that part.
So that's a very difficult question. There's some guidelines that came out from the European Society of, ESCMID, European Society of Clinical Microbiology and Infectious Diseases, which essentially recommended against use of nebulized antimicrobials. And that was done in the context of the fact that essentially there's not enough data to ensure that there's consistent delivery of drug to the likely site of infection. And one of the things that's clear about inappropriate settings for a nebulizer is that it's just going to cause impaction, whereby either the drug just sticks to the nebulizer or it just goes onto the plastic, but essentially doesn't diffuse adequately through the lungs and into the lower lungs in particular. But that being said, the ATS-IDSA guidelines did have a weak recommendation that they could be used in the context of resistant infections as well. And so different people can come to different conclusions. In our practice, in our hospital, we're very fortunate that we don't have significant problems with antimicrobial resistance. But where there is a patient that has a severe pneumonia caused by a pathogen which has a very bad resistance profile, and whereby we have to use a drug which we're concerned is that it won't penetrate effectively into the lungs, such as colistin or aminoglycosides, that's the only time whereby we would try to use that. Sometimes that might be after a couple of days of IV therapy and noticing that we're not seeing any improvement. And as you know, as the situation becomes more critical for patients, sometimes you may reach for different therapies. That tends to be the scenario that we use it. It's not common, but that's partly because of the way that the resistance patterns in Australia are.
And one more point I wanted to ask, like if in case you're using a continuous infusion of beta-lactams, and if the patient is on intermittent dialysis, like most commonly in India, the more common practice is to use intermittent dialysis as compared to CVVSD in Western practice. So if the patient is on infusion of carbapenem and we are using a dialysis intermittently, how do you recommend dosing of carbapenem in those patients?
So a lot of it depends on the carbapenem dose that you're using, because you will get pretty good clearance of the drug with intermittent hemodialysis, but that only runs for 3 or 4 hours a day. So if you have a low dose of drug being continuously infused, and so I'm saying, say, 500 milligrams over the course of the day, like that would be a very low dose, even though that would be okay to be given post-dialysis in a dialysis ward. Continuous infusion is a bit different. You would end up with low drug concentrations. Because the infusion is so slow, it would take a long time for that concentration to then become therapeutic again. And so my recommendation would be that you could either give a little bolus post-dose, post-renal replacement therapy, or alternatively, you could just use a higher renal continuous infusion dose on dialysis days. Maybe you would use 500 milligrams or a gram on non-dialysis days, and then a gram or 1,500 milligrams, meropenem I'm talking about here, on dialysis days, as an example.
So we used to use around 750 milligram post-dialysis in such patient. Will you recommend the same? Like on the day of dialysis, we used to give around 500 to 750 milligram post-dialysis. That's the dose.
Yep.
Because so we don't have a drug monitoring available here very easily.
Sure.
So that's what.
Yeah. So if we're not talking about continuous infusions, then I absolutely agree with you that approach is right. I think that you don't need any more than that kind of dose.
And one last thing about vancomycin. Do you still use vancomycin in your practice? So because most of the European they stopped using vancomycin. I just learned 2 days back that they're not using vancomycin anymore in Europe because of the monitoring problem and probably the availability also. Because they have better drugs. They use ticopenin more than vancomycin. So do you use vancomycin in your practice?
So we do use vancomycin, but we don't have much MRSA. So we don't use as much as we did perhaps 15 years ago. But vancomycin is still widely used in the States, in Canada. It's not used much in the UK because they favour ticoplanin. It is used in different parts of Europe, although linezolid has become a little bit more popular since becoming off patent. But still, I think vancomycin is still quite widely used. It is by far the most studied antimicrobial and remains to be the case. And almost all studies ended up being the same kind of thing too, how to dose it. It's a tough drug, ironically.
Because I remember we used to use trough levels to monitor drug levels. And I have used nearly maybe 4 grams in a day for a young patient who was having augmented clearance. So do you come across the same problem in your ICUs? Augmented clearance?
We've used doses as high as 7 grams as a continuous infusion in the patient. that's very rare. It's not uncommon at all to end up using 5 grams per day as a continuous infusion in neurotrauma patients, young males that are perhaps, under 40 years of age and that don't have kidney dysfunction. That's a very common scenario. So we tend to use intermittent dosing, like 12-hourly dosing of vancomycin, but where it's clear that a patient has a higher drug dosing requirement, then we'll convert to continuous infusion. But yeah, high doses in augmented renal clearance, very well correlated with vancomycin.
And do you use trough levels or you use the MOC and area under curve strategy for the dosing of the vancomycin?
So we're quite comfortable still with trough level monitoring. I do believe that where there's a patient that has a severe MRSA infection, that there is an advantage to AUC monitoring from a safety perspective, and we would look to try and apply that. But that would only be in cases whereby the patient has a severe infection, whereby we're targeting very high drug exposures and making sure that we're also, in doing so, trying to minimize the likelihood of nephrotoxicity.
Thank you so much for your insights. Do you have any more time for questions, madam?
We can have 2 minutes.
Okay. Audience can unmute or put the questions in the chat box.
I don't see any questions, but I have a question. Jason, what is the approach different for acute kidney injury and chronic kidney disease about adjustment of antibiotic dosing?
Almost no difference at all, just purely based on what is the person's creatinine clearance on that specific day for a renally cleared drug, and then to dose for that. It just happens to be that if they have chronic kidney disease and not acute on chronic kidney disease, that you can use that same dose each day. Whereas if it's acute kidney injury, because of the changes that you're likely to see each day, you might have to modulate that dose each day. Whether or not, it depends on the level of sickness severity about the kind of dose that may be given on day one. Maybe an acute kidney injury patient, they're more likely to have an altered volume of distribution as well. And so you might give that patient a slightly higher dose on the first day. But otherwise, I tend to base very much based on what I estimate or measure the renal function to be in that patient if we're talking about a renally cleared drug.
I think we are running out of time, probably. So thank you, Dr. Jason, for your wonderful presentation and also patiently answering all our questions. From the outset, from all of us, very well done, and probably look forward for further association from this side.
Thanks very much for the opportunity to talk. I have an apology to make. I was going to put a picture of the T20 World Champions up on my screen just to demonstrate my love for cricket, because my Indian friends often will do the same when they've just beaten us in a home test in Australia or something similar. So it would have been a nice opportunity to do that because we don't have many wins at the moment, the Australians.
Thank you.
All right, thank you.
Thank you, Jason.
My pleasure. Happy Antimicrobial Awareness Week, everyone.
Dr. Verma, Dr. Verma is already here. I can hear you.
Yeah, Dr. Verma. So it's my privilege to introduce Dr. Muralidhar Verma, who is an associate professor of Department of Infectious Diseases in Kasturba Medical College, Manipal. He was in the inception as well as in the making of department. Dr. Kavdasrao and Dr. Verma work together, and we are very privileged to have you as our infectious ID experts too. So he also serves as the chairperson of our hospital infection control committee. We create excellent output, especially in the times of pandemic. We had fantastic support from him in emergency medicine, and he has a great experience of research, especially clinical and research expertise in IDA, particularly HIV and also bacterial infections. He has published around 79 articles in various peer-reviewed journals. We meet every day, and he supports ourselves and our staff very much in the realm of clinical management too. Thank you, Dr. Verma, for being here, and we expect to hear from you, and we are eager to learn from you.
Thank you, Jairaj. Let me first upload my slides. Can you see my slides, Jairaj? Dr. Jairaj, can you see my slides?
Yes, we can see your slides.
Yeah. Yeah. Some issue with my mouse. 1 minute. Going forward. Yeah. Good afternoon, everyone. And yeah, Jason, hopefully we'll see you next 2020 World Cup, and hopefully India will win in Australia, right? Thank you. That was a wonderful talk and a lot of insights about ICU patients. And we being in India, we are far away from reaching the goal, some of the concepts which you have taught us, right? But we are definitely working towards it. So I will be presenting something completely different. And this presentation is primarily meant for postgraduates and some of the students from pharmacy practice, trying to give you the insights of some of the antimicrobial stewardship. It's a big topic. I try to make it very simple and practical, but we can always have a discussion end of my talk. So let us look at a case, a 48-year-old male who presented to us with no premorbid illness, had fever, body ache, 4 days, breathlessness since 2 days, at admission saturation 90%, he had hypotension. On evaluation, he had ARDS, AKI, and thrombocytopenia. I think this is a very common scenario we all see during the rainy season, and diagnosed to have leptospirosis. And he was started on injection ceftriaxone and a supportive management in the form of ventilation, dialysis, inotropes, etc. So over a period of next few days, like most leptospira patients, he was extubated, he was doing well, his hypoxia was getting better. Then he was planned to shift to the ward. On day 7, when he was planning to shift to the ward, his hypoxia got worse. He had a new onset hypotension. Then his clinical condition rapidly deteriorated. Unfortunately, the culture report, I think it's not shown. Can you see the culture report, Jairaj? I can't see it in my computer. It's not seen.
It's not popping.
Understood. Yeah, no problem. So he had blood, and blood was growing pan-drug resistant Klebsiella, which was resistant to virtually every drug. And unfortunately, patient expired. This is not a very uncommon scenario what we see in our hospital, and not only in our hospital, across India. Patients coming for a disease which could be potentially treated, ending up getting a disease which is almost very difficult to treat. So what we call it as hospital-acquired infections. And most of the hospital-acquired infections are caused due to, nowadays in India and developing countries, is due to pan-drug resistant gram-negative bacilli. So why do we need this antimicrobial stewardship? So that's a big question. So what does this case teach you, which is not uncommon. This is very similar case which we had about a couple of weeks back. The antimicrobial resistance currently kills about 7 lakh patients every year and predicted to increase about 10 million. That we are talking about 1 crore deaths in question of 30 years from now. That's a significant economic burden. As per the WHO data, we have estimated economy affected by the AMR is about 100 trillion annually, right? That is an estimated burden. And as you know, the AMR is not restricted to bacteria alone. It could be due to antiviral drugs, antifungal, and antitubercular drugs. But for today's discussion, we will keep it only for the antimicrobials. So what is driving this AMR? As you know, in healthcare facilities, we all know that it's predominantly the density of the patients. As a result, the bacteria they bring along with them and they transmit within the hospital. So there's it is like having a cricket match with, in Gujarat, we have a lot of people come and watch. It's a high density, huge risk of transmission. There are two areas which we will like to discuss today. One is improper antibiotic prescription in human medicine, but I will stick to predominantly in the hospital area because we will not be able to discuss the rest of the things today. And how inadequate our infection control practices are in most centers in India. And there is an overuse of antibiotics in agriculture, the global travel, poor sanitation, which is a common problem in developing countries, overprescription, lack of vaccines, drug resistance against pathogens. So there are a lot of issues which are driving it, but we will stick to two important topics today. One is the antibiotic prescription in the hospital setup. So does antibiotic sensitive mitigates antibiotic resistance? I think all my images are not coming, unfortunately. I don't know what is the problem. Right. So as you know that going back to the previous slide, when you give an antibiotic, there'll be a selection pressure, right? A sensitive strains will tend to become resistant over a period of time. Even if you give appropriate antibiotic, even if you give adequate dosing, adequate duration, still there will be some amount of resistance. Question now is how can we reduce it? We can never make it zero. We can only reduce it. So what is antimicrobial stewardship? People have tried answering this question, right? Because when we say stewardship, it sounds a little bit strict, right? Steward, ward. It looks like as if somebody is monitoring you and somebody is with a stick behind you. But the idea is not that. Idea is, as you learn from my talk, that it is about working together, right? It is how do we address the issue together, right? So there are different definitions. I just picked up from the CDC Atlanta definition. Antimicrobial is globally defined any activity to optimize drug selection, dosing, duration, and the route of antimicrobial. Looks very simple. Again, as I go on, I will explain you. This is primarily at the patient level. The definition might be a little bit different if you look at country level, community level, or at the hospital level. So it's all about striking the balance between the optimization of patient outcomes and minimizing the antimicrobial resistance. Sorry, I don't know, there's some technical glitch, all my images are gone, right? So end of my talk, I want to be very clear that when you say antimicrobial stewardship, I don't want you to carry home message saying that don't give antibiotics. It's not. We are trying to save a patient, but at the same time minimize the collateral damage for the medications what we are giving to save, right? We in ICUs, especially people working in ICU like Vishal in EMD, we know that sometimes we overdo it and sometimes we underdo it what we want to do. And there is a lot of individuality which comes in. That is where understanding the science behind it and making a proper guidelines will mitigate all these issues. So as I said, AMS can be at the patient level, which will be a predominant discussion today, where we will be using empirical antibiotics, how to decide on that, syndromic treatment, PKPD, which I'm not going to touch today because I've just put them on I deleted them because we had a wonderful talk on that. De-escalation and IV to oral. So some of those topics I'll touch. I'm not going to talk about how to run a stewardship program, how it is interrelated to the IPC program, which are closed jodis, then the structural resources we need, etc., and community level and national guidelines, which is beyond the scope of this today's talk.
Varma, we can share the slides from here if you stop sharing.
Yeah, is the images seen there?
No, not in this.
Yeah.
So I
Then
think
I would prefer having here if the images are not seen, because it'll be easy for my.
No, yeah.
Images are seen, then you can upload it from there.
Yeah, we will try.
Yeah, you can just let me know. Shall I continue or I'll wait for you?
Stop sharing. We will
Yeah.
from here.
I have to stop. Is it done?
Yes.
Next.
Yeah, now it is seen actually, right?
Yes.
Yeah. So somebody is running the this one. Yeah. Just next slide, please. Next slide. Yeah, no, before slide. Before that, yeah. Is it in the slideshow now?
Yes, sir.
Yes.
Yeah. Okay, fine, right. I have one bar which is, yeah, that's fine. So today we are going to discuss primarily about the patient level issues. So simple basic things, and hopefully I'll try to make it a little bit more interactive, and PGs can participate if they can put it in the chat box. Next slide, please. Yeah. So what are the components of antibiotic prescribing practices? This is the one simple slogan which is put up by the Agency of Healthcare Research and Quality, which is the research wing of DHHS, right? Which is very aptly put. The first one is making a diagnosis, which we will go into it. And as you know, that diagnosis is the only thing in medicines. Without diagnosis is nothing, right? And other thing, all patients, how culture should be done and empirical therapy should be decided, then stop whenever not required, narrow it down whenever you get cultures, and then probably give shortest duration, and then change it to oral if required or whenever it is possible. We try to drill in some of the concepts by looking at some of the cases which we have in our hospital. Next slide, please. So before we go on to the actual thing, some important concepts about the AMS and IPC are important. As you know, without IPC, there is no AMS. See, antimicrobial stewardship is about how do we optimize the antibiotics. But if you can prevent an infection, there is no question of giving antibiotics. So that's why always the aim of infection control is to create less opportunity for the stewards to do anything. So it's all about prevention. Classic example is our COVID, where you can remember exactly 1 year back how we were struggling, and there's a lot of media about second wave, etc. But now we are all vaccinated. We are almost like significantly less number of cases. Once we cross the prevention, then it's about control. That's what we were trying to do predominantly in the first wave and second wave. We already have enough infections. We are trying to reduce the spread. That's where the triaging protocols in ICU, when we put it up, how do you isolate a patient, etc. Okay, you have done all that, you still, some patients lived on, then you start the therapy, right? So that's where the stewardship opportunities come. So stewardship always comes after when the prevention and control fail. So that's a very important thing we need to understand. So you have to strengthen your IPC before strengthening your antimicrobial stewardship programs. Next slide, please. So as I said, there are jodi, right? As you know, the 5 moments of hand wash are essential, about almost like we are celebrating the 12th year of 5 moments of hand wash, right? And similarly, the 4 moments of stewardship, they go hand in hand. They are inseparable. Next slide, please. Yeah. So some more important concepts about antimicrobials. Next slide. This is for postgraduates and some of the students who are there. as you know that there are different types of antimicrobial therapies. One is when the patient presents to you, what we give a therapy before our cultures come in or the labs come in, we call empirical therapy. Click again, whoever is running the slideshow. Can you click again? Yeah, this is empirical therapy. Yeah, slow, 1 minute. I'll just keep telling. Yeah. So after that, you send cultures, and then patient, once the culture is seen, or you got a culture and you know what is the organism, what is the sensitivity, and you go for definitive therapy, right? Any drug you give to prevent the whole infection, we call it as prophylaxis. A classic example, I would say, we give TMP SMX to prevent PCP pneumonia. That's what is prophylaxis is about. There's no actual infection, but you want to prevent it. Next click. Click again. Yeah. Yeah. The other one is preemptive therapy. You have a high-risk patient who likely to have infection, but you don't have a proof for it, but you have an indirect evidence, either in the form of, say, an antigen which is positive, or there radiologically which is positive. You want to treat that infection, something. It's typically we use this strategy in high-risk patients, like in oncology patients. Ultimate goal for a good clinician is majority of our empirical therapies should convert into definitive therapies, right? If you're successful in that, that means your stewardship program as a clinician, you're doing a good job, right? And how do we guide clinicians to achieve this? That is one of the important goals of any AMS strategies. Next slide. Yeah. If you look at a patient coming to ED emergency or coming to OPD, for all practical reasons in infectious disease, there are multiple syndromes, right? To help us identifying the potential antibiotics which we can use or when not to use. So this is a very important concept all clinicians should know, practicing physicians should know, because if you want to use stewardship or guidelines, ultimately you need a syndrome, right? Otherwise, it's difficult for you to follow what the recommendations are. So this is the first step you need to know. So I just put it up as a commonest ones. This might change in different, but we have a unique problem in countries like India where we have tropical infections, apart from respiratory, GI, urinary, CNS, skin and soft tissue, and others. So many times we end up giving a couple of extra antibiotics because at that moment we are not sure. Unfortunately, there are no international guidelines recommending this, and there is no good data to help us out. But it is over a period of experience, we have seen that during the peak season of tropical infections, we end up giving additional drugs. So this is where we feel that the local anti-stewardship program should evolve, which, as Jason said, they don't see much gram-negative pan-drug resistant organisms. So that's where the local data becomes extremely important. Go ahead, next slide. Next slide, please. Yeah, so this I put it as, go back, 10 commandments of the antibiotic treatment. This is how I use it, but you can use it anyway. First question you ask is the patient having infection? Second is, what is the clinical syndrome is having? Okay, you have an infection. Is it bacterial, viral, fungal, protozoal, right? If it is viral, you don't need an antibiotic. What is the clinical severity? That decides where the patient goes and how aggressive treatment. How to optimize your empirical therapy. Route of administration, that again depends on severity. Is the patient having drug allergy? Did you take a good history? And then, of course, narrow down at the earliest, plan the duration, up ahead, follow some guidelines, and then finally, if possible or if required, change it to oral. Some of these important questions we will try to address today. Next slide, please. So just to reiterate again, ultimately it boils down to diagnosis, right? That's why I keep telling always, if you have a diagnosis, you can just open a textbook or you can read anywhere and treatment is out there. You don't need. The question is, what will you do interim before the diagnosis is done? That's where your clinical skills are very important. Go ahead. Next slide. Yeah. So we'll discuss some of the cases addressing some of these issues. I didn't cover everything, but some of the important concepts I tried to cover. This is just a picture trying to show how we practice when we practice clinical medicine. Again, these numbers are just arbitrary. These are no reference for this. This is just out of my experience. I put it up. 60 to 70% of the cases what we see in ICUs and ward have good clinical correlation with the lab or better clinical outcome. Over a period of time, I'm finding actually this percentage is dropping because more and more complicated patients are being referred or the hosts are becoming complicated. About 20%, can you click once again? Just click one, yeah, next, that's stopped. So other one is good clinical correlation, lab correlation, but patient does not make out, okay? That we have seen, like the patient which I've shown you, we made a diagnosis, everything is fine, patient passed away due to high. Next click. In some situations, poor clinical correlation, but still patient outcome is good. This is a wonderful thing for all of us because we take credit for all these patients, right? Because the patient does well and they come and say, thank you, doctor, you did well, but actually you did bad clinically. Last one is even worse. You have no clinical correlation. You don't know what is happening, how to correlate, and patient outcome. So I'm not going to discuss about the last three. We'll stick to the first one, that is good clinical correlation and lab correlation and patient outcomes will be good. Go ahead, next one. Next slide. Yeah. Let us start with simple thing. 20-year-old student comes with cough, fever, running nose, sneezing, body ache, 2 days, and no history of wheezing or dyspnea. There's no significant past history. On examination is febrile, heart rate is high, BP is normal, respiratory rate is normal. He has posterior congestive wall, some mild congestion. Otherwise, rest of the systemic examination is normal. So what's a working diagnosis? Can any PG put up in the chat box? It's a straightforward case. I think PGs can put up in the chat box. What is the syndrome we are looking at? Just try to identify the syndrome rather than making a diagnosis. Don't jump to the diagnosis straight away. I think in the era of COVID and influenza, this is a very straightforward case. Anyone there? I can have a look at the chat box. Yeah, I'll give a few seconds. Any of the postgraduates or students can answer this? Okay, we'll go ahead. Next slide, please. Yeah, so this is a clear-cut case of upper respiratory tract infection. So we have identified the syndrome. This patient having infection, that is rule number 1, commandment 1. But the first thing you should realize in majority, more than 90-95% of upper respiratory tract infections are due to viral. So the 4th commandment, that is you don't need an antibiotic for it. So if at all you need an antiviral, right? So overall viral pathogens predominant cause of pharyngitis. And this is one area where antibiotics are grossly misused. It's very, very unfortunate that we use a lot of antibiotics, even mild cases of COVID, which was absolutely not required. Tons and azithromycin and doxycycline were used. So sad. We can use a simple clinical scores like center score. With the help, we can differentiate whether it's a bacterial or not, right? Are the investigations required for this patient? Probably yes. A swab is required to say for COVID and as well as influenza nowadays. Previously, it would have been only COVID. Go ahead, next slide. Yeah, not required. Antibiotics not required. Somebody has correctly answered. So this is again, just to reiterate again, this case does have an infection. Site of infection is respiratory, predominantly upper motor. Cause, upper respiratory. Cause of infection is viral, right? So it's important that to identify. So rest of the questions actually does not matter now. So we can stop the discussion there. So this patient requires, if at all, if you think suspecting influenza, you can put the patient on oseltamivir. Next slide. So message, antibiotics don't kill virus. So don't use antibiotics if your clinical syndrome suggests that it is a viral infection, right? So that's a very important message you need to know. Majority of upper respiratory infections do not require antibiotics. So please don't misuse them. Next slide. Yeah, we'll go on to the next case. That is a female, diabetic, glyco-HB of 9, totally uncontrolled, fever, burning mixtures 6 days, low backache 3 days. On examination, patient has hypotension, pulse is high, high-grade fever, light loin pain and tenderness is there. What's the working diagnosis in this patient? This is a pretty straightforward case. What's the diagnosis? Anyone? Somebody has written urinary tract infection. Can you be better than that? Correct. Your syndrome you have identified. It's predominantly affecting the urinary system. Can it be better than that? Patient has hypotension and has fever. Fever in a UTI, hypotension are unlikely to be lower UTI. So it has to be an upper UTI. So these are the two clinical markers. Of course, there is also complicated UTI. Yeah, fine. Somebody has written, but I would say pyelonephritis or upper UTI is a correct answer. So the diagnosis is that. So do we need an empirical antibiotic for this? Next slide, please. Yeah. So this is the next question. Before we start antibiotics, it's very important that you draw cultures. So that's what we call culture of cultures. So we tend to monitor them, right, and see how cultures have been drawn. So we are encouraging people to draw cultures. If you don't draw a culture, how will you change your empirical drug to a definitive therapy, or how will you narrow it down? So doing cultures is of utmost importance, especially when a patient is having a syndrome of systemic infection. Like in this patient, what cultures will you send? In patient like this, what cultures will you like to send? Next slide, please. What cultures will you send? Any PGs? Yeah, we like to send for blood because we are expecting bacteremia, and then probably urine culture. Absolutely right. Somebody has written correctly. So message is send cultures whenever clinically indicated, up ahead before you start antibiotics. Next slide. Yeah, so in this patient, clinical syndrome is urinary tract infection. We can go one step ahead and say it's pyelonephritis. Next slide. So how do you choose empirical therapy? This is a tough question to answer. So now your first step to choose an empirical antibiotic is always identifying the clinical syndrome, right? That's utmost important. So how do you identify clinical syndrome? Good history, examination, and basic labs. Once you identify clinical syndrome, then you can guess what is a likely organism and also probably guess the resistance pattern. We'll not go into too much details of it, and then also decide on what is the route of administration. So I'm not going to about the resistance pattern. We will stick on to the simple organism. So how do you choose? That's always difficult, right? Next slide, please. Yeah. So can we use a local antibiogram and then antibiotic policy, or shall we use national or international? That's where the debate is. Next slide, please. So let me start with a simple thing. So if you read Davidson, like an undergraduate, for the same syndrome, we are supposed to use coamoxiclav or ciprofloxacin. So how many of you sitting here will agree I will give coamoxiclav for this patient? Means none of the clinicians will use this, right? Even though it's a standard practice probably in UK, because their resistance pattern in their community is different than ours. So obviously we should not use standard textbooks to decide about the antibiotics for empirical therapy. Go ahead, next slide. Next slide, please. Yeah, can we use a national guidelines? So national guidelines says Pictaz or Ertapenem. Probably it's not a bad choice, but again, subtle difference will come. So next slide. So guidelines are always confusing. So guidelines, we often think, is it correct? Is it wrong? Because how is it not matching up to what I am seeing and why the clinical outcomes are so different, right? So how do you answer this question? How do you solve this puzzle? Next slide. That is where it's important that every hospital or local area start doing antibiograms. Okay, understand the resistance pattern within the hospital. That's what we call it as think local always. Infectious disease is one branch where local data is far more important than any international data. right? We can, for cardiology, for neurology, probably you can use guidelines, but here everything is local. So it will give us a resistance pattern. Just go ahead, next slide, just to give a snapshot about this. Go ahead. So this is how an antibiogram looks like, where organisms will be given sensitivity patterns. They keep changing. Next slide, please. And then based on that, antibiotic policy is created. Next slide, please. So just to give a snapshot again, if you go by KH antibiotic policy, we are saying cephalosporin sulbactam. Of course, part of it is cut here, some slide issue here, right? So next slide. So the idea is when you start empirical therapy, start smart. So how do you say you are smart? So use local data. If you don't have a local data in your hospital, try to use the community data, look at the net and see, or probably state or national. That is the way. But if you have a local data, they are anytime better than national or international or even a standard textbook. So that's a very important concept when you start empirical therapy. Remember that when you start empirical therapy, your focus is to save patient. We are not unduly worried about resistance at that time, even though it's back of our mind. But our importance is to save the patient. Remember, all these patients are quite sick, like a lady I described. Go ahead, next slide. So day 3, culture report has come. Go ahead, next slide. So here blood is grown E. coli. Are you expecting this organism? Absolutely. E. coli is the commonest for 70 to 73% of all the cultures of urine. UTIs are due to E. coli. So we've expected, and here you can see that even though we started cephalosporin sulbactam or pictazo, we see that it is sensitive to third generation cephalosporins or even say ciprofloxacin. But because there's a bacteremia, we prefer using Betalactam group of drugs. So what do you want to do then? So you step down to ceftriaxone. That is what was done for this patient. Go ahead, next slide. So your empirical therapy has become a definitive therapy now. Not only you did that, but you've gone one step and you have actually narrowed down your antibiotic choice. Go ahead. So the important thing you need to, next slide please. It is important to realize that we could be able to do that because we did cultures up ahead and we had a good clinical correlation with the labs and we had a good clinical judgment. So that all this will contribute to our stewardship program. So make sure you change the antibiotic after culture. If cultures are not there, again, it's a challenging thing, then probably you should go back to your standard guidelines. And additional antibiotics, you can always stop and always narrow it down. Next one. Next slide, please. So there are a lot of de-escalation. There's a lot of advantages of de-escalation. Like you can reduce the selection pressure, you can reduce the length of stay, you can reduce the drug side effects, the cost. There are a hell lot of advantages by de-escalation. So it's a very important concept to reduce your selection pressure on antibiotic resistance. Go ahead, next slide. So start smart, absolutely correct, but draw cultures, then focus. That's a very important concept you need to understand. So the moment you get a cultures, focus down. But in reality, about most clinicians will agree 40 to 60%, depending upon where you practice and how good is your lab, we don't get culture. So what do we do then? Then we go by your clinical judgment. So, but that will encourage you, how do you improve your culturing rate and how to improve your labs? Go ahead. Next slide. So this I'm not going to cover, right? So I've hit all my slides. So we will go on to the next slide. Yeah. So here one more case, 57-year-old female, cough, sputum, fever, right, pleuritic chest pain, 5 days, diagnosed as severe community-acquired pneumonia and started on pictazo. On 5th day, patient was asymptomatic, labs got better, chest x-rays improved. So here we have already marched on quite a bit. So is this patient having infection? Yes. Where is the site of infection? It is pneumonia, so respiratory. We said it is bacterial. Then we chose your empirical antibiotic. Then we have decided that we will continue it till the patient is better. So we have already reached commandment number 6 or 7, right? So now question is, patient is getting better. how do you decide the duration of antibiotic? How long will you give? So some of the PGs can answer this. This is a clear-cut case of community-acquired pneumonia. So what do you think, the PGs? How long does this patient require? Shall we stop antibiotic on 5th day because patient is much better, probably all set to go home and is asking? Anyone? Medicine PGs or somebody from ED? What should be the duration of antibiotics? 7 to 14 days. I mean, that's a huge range. I mean, it's like Kashmir to Kanyakumari, I would say. It's too wide. 7 days? Okay, fine. That's more. Yeah. So world is actually moving to shorter and shorter regimens, right? Because there's more and more evidence and convincing data coming that shorter regimens are as good. And science-wise also it makes sense because most of the bacteria would have died by the time you've given 4 to 5 days. It's actually the effects of the inflammation what you're seeing. So we don't need that long antibiotics. I think in various syndromes, the data is coming. Can you go for the next slide, please? I have about 5 minutes. Yeah, so don't go by 7, 14, 10 rule. Remember, these numbers are thrown into our textbooks because the studies were conducted like that. There is no rationale about that 7, 10. You can stop an antibiotic on 9th day. Nobody stops you from doing that. So it's all again clinical judgment and data. You can stop it on 4th day. You will be surprised to look at some of the recommendations for duration of antibiotic. Next slide, please. So this is again American Thoracic. They recommend only 5 days to 6, 7 days if the duration, I mean, if the patient is clinically stable, right? It's a very wonderful document. People who are interested can look into it. Next slide. Some data which is showing there, even for bacteremia, they're saying it's only 7 days, right? So people are moving in all syndromes. Remember, these are bacteremic patients, which we were all taught bacteremia don't be less than 10 or 14 days. Okay, so things are changing rapidly. So longer duration is a driving force for AMR. Next slide, please. In fact, there are studies looking at 3 days. Okay, can you believe it? It's just 3 days of antibiotics for pneumonia, right? So it's always question yourself whenever you're prolonging your therapy. Again, clinical judgment is important. Patient should be clinically stable. Don't go by just guideline. Okay, this evidence shows that I'm going to stop it. You balance out your patient outcomes with AMR. Next slide. So shorter is better and in fact safer also now. Next slide. So just to complete the last few slides, 36-year-old fever, pain in the right leg, pus discharge on evaluation, severe skin and soft tissue infection. Remember, this patient has discharge. So if you go by any guidelines, a pus discharge, skin and soft tissue, we should always cover MRSA. So this is definitely an infection. This is a bacterial infection. Patient requires therapy and patient requires MRSA. So patient was started on Vancomycin. Go ahead. Next slide. So then patient was afebrile, vitals are stable, is tolerating orally. Can we switch on to oral tablets? Yes. Definitely, we can switch on to oral therapy because we have wonderful oral available now. Patient is clinically stable. So switch to IV to oral is a very important option. There are a lot of advantages for it. Next slide, please. Here we can switch to clindamycin. Like it lowers the cost. It reduces, for me, from infection control point of view, it reduces line-related infections. We can discharge the patient. So even administrators are happy. So a lot of advantages, but you need to select your patients. Go ahead, next slide. This slide just illustrates, next slide, please. This slide illustrates, go back, one slide, please. This slide illustrates you the bioavailability. So when you choose your oral antibiotic, make sure you choose it appropriately. So is it available in your country or a locality? Second, is it appropriate for that patient and the organism? That's a very important question you need to ask, right? This is just a graph showing all the details of it. Next slide. Yeah. So one more patient, a 45-year-old male, CKD, diabetes, high-grade fever, chills, 5 days, right lower limb cellulitis diagnosed, hypotension. So then pulse was high, diagnosis. Again, skin and soft tissue infection, severe form. What should be the antibiotic? Again, here it is cellulitis. So we tend to treat streptococcus. We may not require MRSA cover in this patient. Go ahead, next slide. So patient was started on ceftriaxone. So, and the blood turned out to be streptococcus as expected, and it is sensitive to ceftriaxone. The problem is next. Go ahead, next slide, please. Then immediately, as you can see, patient developed a rash, right? You developed a significant rash in the hands, body, intense itching on day 2 of ceftriaxone. Even though we expect the ceftriaxone to cause, sometimes the delayed reactions are known to occur with beta-lactams, but drug allergy is a big challenge for us. Next slide. So penicillin allergy is there, but I feel it's overestimated in countries like India. It's difficult to diagnose, right? It's reported about 10%, but I feel, I mean, majority people agree that actually, if you look at some of the statements by CDC, it's an overestimate, but it's an issue. For a mild to severe reaction, or it can be immediate or it can be late. So all these are possible. Don't think that you give a test dose. If test dose is positive, patient is going to have a reaction. It may not work out that way. It all depends on what is mediating the allergy. A detailed drug allergy history is very important. I put up in my 10 commandments. Look, ask for a simple drug allergy. The problem is patient's allergy means it could be anything. It could be due to dust, pollen. So they will say that. I mean, all of clinicians, we have wonderful experience with the radiologists always cancelling our CT scan. They said he has an allergy, and humpty number of times we ended up giving steroids. I mean, that should not be that aggressive history, but it's a good thing to ask before you start, especially beta-lactams, drug allergy. And the other thing is, I think the test dose is being used for ages. I think we are overusing it. For beta-lactams, probably yes. For non-beta-lactam antibiotic groups, I think we should slowly come out of doing test dosing, right? Anyhow, that's a subject some other day we can discuss, and look for an alternative to drugs. Next slide, please. So message, inquire about drug allergies. So these are some of the important messages you should know. Next slide, I think I'm almost done. Yeah, in summary, this again tells you, except 1 or 2, the important messages when you take a decision to start an antibiotic. The first most important, as I told you, make a diagnosis, make a clinical syndromic diagnosis, right? That's very, very important. Diagnosis will direct you what to do next. Okay, as I said, diagnosis is the only thing in medicine. Obtain cultures whenever it's important. Start empirical therapy. And start antibiotics only if it is indicated. It's viral, please don't start antibiotic. Stop it whenever not required. Narrow it down as early you get a cultures. Change to oral. Duration, keep it as short as possible. Go by clinical judgment and standard guidelines. And of course, ask for allergy. Next slide. Yeah, so if you want to be successful, theoretical part is fine, but you need to have a good team with you. You need to make friends. You have to be a role model. Work as a team. What concept we say is don't work vertically, right? Work horizontally. That means everybody is equal, and work with a passion. So infection prevention and AMS, you have to have a passion because there are a lot of hurdles for all this, because we need to tackle a lot of people to convince what you're trying to tell, right? These are very important concepts we need to understand when we run a stewardship program. Next slide. So just to end, Alexander Fleming got Nobel Peace Prize in 1945. So he gave a very important statement. I'm sure all of you know about this. The time has come when penicillin can be bought by anyone in the shops, which we are here right now in India. Then there is a danger that ignorant man may easily underdose himself. PKPD, he knew that time. Exposing to the microbes to non-lethal quantities. That means subnormal doses of drug and make them resistant. So this was predicted almost like 70 years back, right? Phenomenal. Next slide. So I like to end with just like we have carbon footprint, we have antibiotic footprint. right? So let us join together to reduce antibiotic resistance and always work together with prevention, right? Prevention, then only the treatment. Thank you very much. Next slide, please. That's the last slide. Thank you. If there are any questions, I will like to take.
Thank you very much, Dr. Verma. As always, you had very important, very important keywords and notations, which is very important take-home points for the postgraduates and also the pharmacy students out there. It's very important that there are certain points you already mentioned. What are things you will be looking for once you're starting your practice? One is you have an antibiotic steward program. What is your antibiogram? Who's your ID expert? Or how you're going to work your team? These are important things for any aspiring young clinicians who is really wanting to save life from the patients who are already infected. So the most important thing, if I'm taking the take-home point, will be that antibiotic footprint, because that is a very important keyword I will take probably, which I will inform my students here. And I think it's very important that, as a human being and as a practicing clinician, we have to be very clear that there is not much antibiotics in the pipeline, and there's $1 million research which is going futile because of our misusing in the poultry to aquaculture to so many other things. And being responsible clinicians and pharmacy experts, we should always be very clear about what we are doing is right practice. Thank you very much. I would like to have some questions from the students and audience here, and we can have it in the chat box, and Dr. Verma probably will deal with that. Yeah. One more point I wanted to make here is the culture of culture, right? To how you are taking the culture and how you are, the whole process of doing a culture is as we would like to emphasize, because there's no, once you're shooting an antibiotic then trying to take culture, probably the timing is completely wrong. You almost made the patient survival a half chance, right? So over to the students, and we will take some questions here.
I think there's one question.
Yeah, there's one question. How to convince clinicians to have shorter drug durations when there is no clear guidelines? Or
one single strategy will never work, right? I think you need time and you need a good team. So one thing we understood in infection control also in the last 20 years or so I've been working, right? You have to show results. So don't try to replace them, right? Be partner with them, show that you try this strategy, it will work, right? That is the mantra we have always been trying. You don't try to compete with them and try to dominate them. That is the first thing, right? The strategies used in West will be completely different than Indian doctors, because data you can produce that will help us, because that will help us convincing ourselves first, and then it will help you during the discussion with the clinicians, right? But ultimately, a clinician will listen to you if you say that you use a shorter duration, and look at in some patients you try. That is how we enter into their mind, right? Like, for example, even for some of the surgical units when we were working, we said try. So that brought out some change. I still remember there was a lot of hindrance even to send blood cultures initially because of the cost constraints. Now, in fact, we have gone to the other end that we are doing too many blood cultures to my comfort, right? And our contamination rates are very high. So both are extreme, but ultimately, I think where you practice is a strategy. So my strategy has always been a partner with them, show them results during discussion so that there is one. Don't ever be above them. Then the whole program will collapse. Never try to dominate anything. That is the way it works. So it might be completely different in the West. When I went to Australia, US, or in Europe, they look at data, right? You present data, then I'm sure Vishal might know because he worked in Oman. So they look at data, then they and of course this thing. Actually, there are a couple of very interesting articles published about a year back in CMI, Clinical Microbiology and Infection, where how to run a stewardship program. The one which got highest confidence, highest odds ratio was interpersonal relations. So interpersonal relations have a huge impact in running IPC and AMS programs. So you need to have very good interpersonal relations to run your program. In fact, p-value was very significant. I still remember reading that article. So no single strategy.
Any further questions from audience?
I can see one more. There's some confusion regarding duration. In Saudi Arabia, we use 7 days only. I think that was with context of the CAP, I think, community acquired pneumonia. Yeah, I think it's correct. Vishal might add, I have not worked in Middle East. There, I think the stick works very well. The ministry runs the whole show. You can't just beat them. In India, we run in a democratic country. So 7 days means it's 7 days there. At least I don't know. That's what my friends told me. Is it right, Vishal? You can't be 8th day.
Actually, there is a clinical pharmacist and pharmacy in charge who will be supervising your prescription.
Okay.
And they are given clear-cut guidelines who can prescribe what antibiotics. So if as an intensivist, if I prescribe a broad spectrum, piperacillin, tazobactam, by next 3 days, I must get an approval for it to give for the next day. So if I don't get an approval, even if I write a prescription, the pharmacy will not dispense the medicine dose. It is that strict in some places, but I think, as you rightly said,
what happens? The clinician makes noise and say,
no, I want no. Even if he makes noise, they will not give.
Okay, what do you do if there are long holidays? Say Ramzan.
No, whatever it is online system. Nobody can say I'm not on this online system. Nobody can bypass it.
So at least in Europe and US, it is a little bit laxer. There is a teamwork.
We can always convince our colleagues, like as you said, communication. So sometimes, we were not convinced about, stopping it immediately because patient was still sick. So we used to have a, online chat or call the ID and discuss probably this is not the right time to de-escalate. Let us wait for 2 days or let us wait for clinical recovery. And obviously they used to oblige because that is how you, as you rightly mentioned, the most important point is relationship. And probably that's what helps you in guiding.
Yeah.
So obviously they used to oblige, approve for 2 days. And then when everybody is convinced that, okay, it's not required, we used to stop. And we never used to follow 7 days. We used to stop for 3 days, 6 days, 9 days. So whenever you feel
there is no uniform pattern. Yeah, I agree.
So no mantra of 7 or 10 days. No
similar system in US. I think they sit and partner out. But what I understood, usually in some Western countries, the clinicians dominate the pharmacists. It all depends on how senior the pharmacist is. Yep. Right? Somebody like Jason, probably they have to listen to him because he's too senior and he has 450 publications. You can't question him then, right? So, and somebody who's just joined now, he said, who are you? Get lost. Right. So I think it's important to understand the small things when you run programs, right? But working as a team, as you rightly said.
One more point would like to put here is the drug-induced fevers with antibiotics itself. And also you already mentioned that the inflammatory process will outlive the bacteria and you may be having fever. So probably a bit more mention for the young students out there who is going to be the next clinicians.
Yeah, I think some more questions are there.
How to determine the optimal time duration for antibiotics is from Sriram. So probably it is
any idea about antibiotic use and resistance, laboratory and pharmacy? If yes, who is responsible for it?
AUC maybe.
Means they're trying to ask who will be responsible, the lab and the pharmacist working together. That is what they're trying to ask. I'm not getting that. Dominic.
Is mentioning the area under the curve? AUC?
No. I don't think so. Resistance area under the curve. I don't know. I'm sorry, Dominic, I'm not able to get you, but I'll take the next question. How to determine the optimal time duration? I think I've already mentioned that. I think the world is slowly growing from standard 7, 10, 14 regimen like that, and more a clinical judgment. When you say clinical, it is your vitals, your site of infection improvement based on radiology, etc., and your inflammatory markers. And then finally, your hospital protocols. I think if these 4 are in line, you can stop. So that's what is optimal therapy. But worldwide, there is a tendency in all syndromes to become shorter and shorter regimens, right? Including tropical infections. Then for leptospira, actually, there's a debate whether we really need an antibiotic. Most of the time, we don't need more than 4 to 5 days. Yeah.
I think even the biomarkers will help us to determine
a lot of improvement. But as we are taught in first class, no single stick, we can break all 6. So it's together everything. Don't use only procal. Procal is negative, everything is all right. I mean, That's, I think Vishal knows how many patients we burnt our fingers like that during COVID. Yeah. So let us not use only one thing and say everything is fine. I don't know. Dominic, can you explain that question? So I didn't get, in Saudi Arabia, they use AUR for pharmacy and laboratory, who is responsible to do antimicrobial use and resistance. Vishal should take this. Probably it's all how the ministry runs.
No,
Exactly
can you
what
please
you're telling,
explain?
right?
I'm not able to
Pharmacists-
get the word AUR.
It's area under the curve, maybe for the.
No, it's not enter area under curve. I think anti-utilization rates. It is antibiotic utilization rates.
Yeah.
So I think pharmacy and lab determine, right? As you said, right? It's not the clinician alone. The pharmacist will go and talk to the lab and they look at the resistance, microbiologists, and then talk to the clinician. This is what we decide. If you agree, you do it. Otherwise, we have a discussion. I think that's what it is. We don't have such system. We are a long way to go, right? Because of various reasons how Indian healthcare system works, right? So everybody is responsible. As you said, who is responsible? I think clinician is topmost priority for deciding on the resistance, right? And we are all part of the same group. But we don't want to lose patients like what I've described, right? So it's a very common scenario now, losing patients due to pan-drug resistant gram-negative bacilli. I think it's 5 o'clock. Are there any further questions, or Kavita, you want to continue?
No, I think we can conclude the session. I thank the speaker, Dr. Verma, Dr. Jason, and the moderators, Dr. Jairaj and Dr. Vishal, for the excellent program. We would like to play a video before I move on to tomorrow's program.
They will take a photo.
Join from that side. Alright.
We'll take it and we will get on camera.
I thank all the participants who have been very interactive and have attended this webinar. For tomorrow, the program starts at 4 o'clock. We have an exciting quiz. We have 5 people who have been selected. Dr. Manish Kumar from Government Doon Medical College, Dehradun. Dr. Ankit Mittal, All India Institute of Medical Science, New Delhi. Dr. Rahul Garg, Indian Institute of Liver and Biliary Science, New Delhi. Dr. Siddharth, KMC Manipal. Dr. Rohit Gupta, ESI Hospital, Delhi. So all 5 participants will be involved in the quiz. So I request many delegates, as many delegates, to join and encourage the participants. There will be an exciting quiz program to start at 4 o'clock tomorrow. Until then, goodbye. I request all the panelists to switch on their videos for a photo shoot. Nitin Gupta. Thank you.
Thank you.
Thank you. Thank you, Dr. Kavita and Dr. Verma.
Thank you very much.
Thank you.
much.